Thanks for having me. I'm going to do a quick summary on Peyronie's disease, different treatment options, and what can we offer patients. My only disclosure is that I participated in a post-fellowship workshop that was sponsored by Endo for 4 weeks. This is a little bit of a background about Peyronie's. I'm sure most of people know a little bit about it. It's an inflammatory disease of the tunica albuginea that leads into some sexual dysfunction as well as change in shape, length, and anatomy of the penis. It is thought to be due to a microvascular injury during either a semi-erect or a full erect state with penile buckling, leading to, again, a microtrauma that leads to deposit of collagen, mainly type 3. There are some predisposing factors that can be associated with it, like diabetes and ED, and the prevalence is depending on the study, but it's mentioned anywhere between 0.5% to 20%. It seems like most people agree that it's somewhere around 5 to 9% in the general population, and the average age of presentation is 57. Again, Peyronie's comes, as I say, in all different shapes, sizes, and forms. You can get curvatures to the right, left, dorsal, ventral, hourglass, indentations, shortening, although the most predominant form seems to be dorsal. It is important to mention that most patients with Peyronie's disease don't only have the anatomic changes, but most of them do report emotional distress, symptoms of depression. Some of them are on the severe side, relationship difficulties, penetration difficulties. So there's a lot of psychological component to this disease that we need to be aware of as we treat those men. Evaluation, just like any other condition, medical history, again, checking on the physiologic status of the patient, familial traits. We know also it's associated with Dupuytren contractures in about 30% of men. It also seems to be run in family, so there's a genetic component to it. Doing a physical exam to identify the plaque, the location, the number, and some patients do present with pictures, but other tools you can have is in-office intracavernosal injection or doing a penile Doppler. The AUA does mention in their guidelines is that if you were going to go with an invasive treatment, which includes surgery or intralesional therapy, they do recommend doing an in-office assessment at least, either with an ICI. I do like to get Dopplers when available on patients, especially if we're going to do with also a invasive treatment like intralesional therapy or surgery, to also get an idea about the vascular integrity of the penis. Especially that a lot of the treatments will lead to some ED side effects, so I like to have that information beforehand. In terms of treatment options, there's a lot that has been tried for Peyronie's. There are some that are actually effective. We'll go through them quick. This is a slide from the AUA guideline giving a kind of an algorithm to how to go through those treatment options with the patients. I think the most important thing to recognize or to ask the patients is how their erectile or sexual function is. What I tell patients is that we can fix the curvature, but if you're not able to get a good enough erection for penetration, I didn't really help you by making the curvature less. So getting a good baseline of what their sexual and erectile function is kind of helps steer the conversation in which way we want to go, but also recognizing that some of those patients come with ED, whether it's psychological or pathological from the disease, is sometimes hard to tease. To go quickly through the if you will, the non-invasive therapies first, I wanted to mention a study by Dr. Mohal that looked at the natural history of the disease, meaning that if we don't do anything for those patients and we monitor them for 12 months, what do we expect to see? A lot of patients that have pain with erections reached 89% of them, the pain was gone by 12 months. 12% of patients, their curvature improved, but the majority of them either stabilized or worsened over the active phase of the disease in the beginning. AUA guidelines, again, mention some oral therapies that we can use. It's important to mention that most of those studies were observational studies that included less than 100 patients, and it wasn't a randomized clinical trial. And most of the results were really just what the patient was reporting rather than any active measurement of outcomes. There are some topical treatments as well. It's important to mention some mechanical therapies that are available out there. Again, most of those studies are not great or randomized. Most of them are observational on vacuum devices and traction devices that require a lot of patient participation for many hours a day. More recently, in the last couple of years, we have they call it a second generation mechanical therapy, which is a penile traction device with the name of Restorex that seem to offer a little bit more than what we've previously seen with mechanical therapies. Some improvement with curvature, with lengthening, as well as reported better erectile function afterwards. Besides oral therapy and mechanical therapy, we'll talk about the intralesional collagenase therapy. This is an FDA-approved treatment for Peyronie's disease. It is approved based on 2 clinical trials that we're going to get into shortly, but typically with the inclusion criteria for this study included patients with curvatures between 30 to 90 degrees. They excluded hourglass deformities, ventral curvatures, calcified plaques, and any plaques that are proximal to the shaft of the penis. 2 trials were done, Impress 1 and Impress 2. They were pretty identical in their design. They included about, I think, about 500 men each, and they were randomized to 2 groups, 2 to 1 by placebo and intralesional therapy. The outcomes were improvement in curvature, patient bother. There was a questionnaire that they used about the patient's satisfaction with the treatment, and then there was a report about possible side effects and complications. The 2 trials showed very similar results. Patients who received intralesional therapy with a collagenase had a statistically significant improvement in their curvature, somewhere around 35% compared to baseline. Now, it's important to mention, and this comes up a lot, is that the placebo group did see also an improvement in their curvature. So the difference was there and was statistically significant. But there are some discussions about this trial that the placebo group itself was, or the average of the placebo group was influenced by a small subset of the placebo group that showed significant improvement. But we'll get into that a little bit more. So again, study 1 showed a significant improvement in the curvature of about 35%, and then as well as the patient bother score. So this is a patient-reported questionnaire. It's important to mention it's not a validated questionnaire, but it is something that we've seen from this study and we rely on when we counsel our patients. After the FDA approval in 2013, we've learned more about intralesional therapy since then. They ran different analyses on the group that was involved in the trial, and they separated patients between 30 to 60 and 60 to 90, and both groups seemed to have similar improvement of 35 degrees. So people had more improvement in curvature in the group that had a higher curvature. They looked also at the duration of how long they've had Peyronie's disease. They divided them to 0 to 1 year, 2 to 4, and more than 4. And it doesn't seem that the duration affect the response to Peyronie's to the treatment. Now, when the trial was done, they wanted to stick with what we typically offer for Peyronie's disease treatment, which is treat in the stable phase of the disease. So this is a study looking at would collagenase be a candidate to be offered during the active phase, and it did show that there was no difference in response whether you go with the active phase or in the chronic phase or the stable phase. It's important to mention that what they defined as an active phase, they included 2 different patient populations. It's either that they had symptoms for less than 6 months or less than 12 months with pain still with the plaque. Another thing we learned about XIAFLEX is can we improve those results if we combine it with penile traction? This was a study out of Mayo Clinic. They looked at all their collagenase treatment patients, and they looked at those who received only the injections versus patients who received injections and some kind of traction that was not the Restorex penile traction device, and the third group that received traction with Restorex as well as the collagenase therapy. And the ones that I want to point out is the improvement of the curvature was significant. It increased to 51% as opposed to 30% with only the collagenase treatment. And there was lengthening of the stretch penile length, or increase in stretch penile length with the traction device that was also significant. So I thought that was an important study to also mention that we can improve some of the results that we can get from collagenase. Those are different ways of showing those results. The first one showing improvement in the stretch penile length and statistically significant improvement of the curvature correction with the penile traction. Can patients undergo more than 4 cycles? This is a small study looking at patients who have failed to reach the results that they wanted from the first cycle. Is there a benefit from undergoing a second? And they actually went ahead and they tried it a third time in some patients. There was a portion of the patients that responded to the second round. It was, I think it was small. It was 22 out of 57 patients and way less patients in the third round. But if patients want to try a second round and they are opposed to any other kind of treatment, there might be some benefit from doing it. More importantly, I want to point out at the bottom of the slide is that there was no increase on any adverse effects from rupture hematoma from providing more collagenase treatments than just 8 injections. The initial study did exclude patients with ventral curvatures. So this is another study looking at can we use intralesional collagenase for ventral curvatures, and it seems that it is effective and safe, at least according to this cohort. Patients with ventral and lateral curvatures had more improvement than patients with dorsal curvatures, and there was no urethral side effects in terms of bleeding or urethral injury from this study. So overall, we've learned more about intralesional therapy since it came out and has been FDA approved, and it seems to be we're able to use it more than what the initial recommendation is for it, as long as we counsel patients correctly, which we'll get to at the end of this talk. The last thing I want to talk about intralesional therapy, one of the main downsides or complications is corporal rupture that happened at a level of 0.5% and significant hematoma that might need some drainage also at a 0.5% rate roughly. So those are the two complications that we warn patients about. What did we learn about those corporal ruptures since we started using it more often? Many surgeons that have tried to fix those surgically, because this is what they did in the trial, had hard time being able to close the tissue and find good tissue to be able to repair it, and sometimes they had to use some grafts. So there are 2 reports, one from Hellstrom and one from Trost, looking at conservatively managing those fractures, and according to the reports, there has no worsening of ED function if you just observe those fractures, and some report that the correction of curvature was more than just what we expect with Xiaflex. So those are 2 promising reports. I do want to mention that those studies were mainly patient report and surgeon's reports. It wasn't really based on any formal questionnaires. Besides intralesional treatment, we have some surgical options that we're going to go through as well quick. We have tonical plication, incision and grafting, and penile implants. Penile implants are typically for patients that are not able to achieve good erection medically or on their own, and we'll talk about some ancillary procedures you can do to fix the curvature. Tonical plication indicated for patients that have a curvature of about 60 to 70 degrees or less, and then it is in the stable phase because we don't want to fix it before it's done forming. and patients have to be able to achieve an erection for intercourse with medical therapy, whether it's oral, but also some people will allow some intracavernosal injections as well. Contraindications are destabilizing hourglass deformity, significant loss of length, penile curvature more than 90 degrees, and then maybe some severe plaque calcifications would not be a good idea for the plication. There are different ways of doing this procedure. There's an incisional, and non-incisional that we're going to go through. So the excisional one, example like a Nesbitt procedure, would be removing small areas of tunica and then closing it at the opposite side of where the plaque is. Another one will be opening the corpora vertically and closing it horizontally, again on the opposite side of where the plaque is. The non-incisional will be just placing plication sutures at the area of maximal curvature on the opposite side as well, using non-absorbable sutures. And there is the 16-dot plication technique, which uses kind of a low-tension sutures on the opposite end as well to fix curvature. What do you expect complications from tunical plication procedures? Curvature recurrence, depending on the study, somewhere between 7 to 10%. Erectile dysfunction, again, reported between 0 to 22%. You'll see a lot of ranges for those because those studies were all, most of them were single surgeon or single center, so we were trying to have a range for those reported side effects from it. Suture granuloma, glans hypostasia was reported from 0 to 21%, and the most important thing is penile shortening. Penile shortening, I think, is the most important thing that maybe have some patients fear undergoing plication or leave it as a second option, given that most patients already come complaining about losing some length, and then if we tell them that we're going to make things even shorter, I think that typically deters some patients. But almost all studies mention penile shortening with plication. The good news is that most patients, about 75% roughly, have less than 1.5 centimeter of shortening, which is considered to be non-significant, but there are about 25% of patients that will get more than that. And I think it's somewhat related to how much curvature they were starting with. That being said, plication does not address any hourglass or indentation. So there are a couple of reports about extratunical plication using grafts to fill in those indentations with what seem to be good results. No major reports of graft rejection or infection, but we do have reports of patient visibly and as well as feeling that graft more in the flaccid state than in the erect state, but it still is something that might bother some patients. Incision and grafting, usually preserved for patients that have severe curvature, more than 60, 70 degrees, or a destabilizing hinge effect. We have multiple choices of grafts that has been used in the literature. This table kind of summarizes what has been published in the literature before. Incision and grafting is a good option, but it doesn't come without any complications. Curvature recurrence from 10 to 30%. Erectile dysfunction is much more than plication because we are violating the tunica and we're using a graft. Change in penile sensation. Different reports of penile shortening. I think that's related to maybe graft thickening afterwards or contraction, although some reports do say that they see some increase in penile length afterwards because of cutting the plaque. Patients that are unable to have a good erectile function, fixing the curvature alone is not very helpful. So we have an option of doing a penile implant to address both ED as well as PD. And then we have a set of different adjunct procedures, if you will, to address the curvature. It is important to mention that in about 5% of patients, just placing the penile implant itself will take care of the curvature because of the thinness, the thin corpora that might be able to just get stretched out by placing the implant, but we do have other procedures that we can do. I recognize that that might be a little bit controversial. There are a lot of people that have abandoned, if you will, modeling in the setting of a penile implant, mainly because of the complication that can happen with the urethral injury as well as migration of the device. I still do it in some cases either alone if it's going to correct the curvature or before I do any other procedures, because if I can get the curvature to be less, then that is in favor of doing less afterwards in terms of grafting or incision. If you get to a point where there's less than 30 degrees left, you do not need to do any additional procedures. This is probably not something that we see very often, but this is complete correction of curvature with just placing the implant and doing penile modeling. Afterwards, if you still have more than 30 degrees, you have some couple options. Some people do plication with the implant, but other people do incision with it. So incisions that were done at, again, the area of maximal curvature. And if you have a defect more than 2 centimeters in any direction, then the recommendation is usually to place a graft. Different publications were done about the intestinal graft, collagen fleece that might not need suturing, or the pericardium from a cadaver. Whatever you can do to get the penis less curved will be the goal, and ideally less than 30 degrees. Doing the additional procedures can increase some of the complications that we have with penile implant. Increased risk of an infection has been reported between none to up to 12%. Decrease in penile sensation, need for surgical revision, and again, shortening versus lengthening depending, I guess, on where we started and what kind of procedures we have done. To wrap this talk, I would like to spend this slide to talk about how I approach this with patients. Again, I do want to stress again that most of those patients are coming with some symptoms of depression, distress, loss of confidence, especially if they are not in a relationship and they want to start dating again. Difficulty in relationship because they might think they might causing the female partner some pain, or so there's a lot of different psychological factors that come with it. Operating on the penis is not operating on just a regular organ. There's a different relationship that people have with their genital area as compared to any other part of their body. I also recognize that none of our treatments are perfect or ideal. We are not able to reverse Peyronie's process and bring back the patients to how they were before. And this is something I'm upfront on, and I tell patients about in their first consultation, is that we can make things better and functional, but there's unlikely that we're going to be able to reverse that. Finally, most patients also come with complaints about indentations, change in shape that distress them, and shortening. So offering patients treatments, mostly surgically, that will cause probably ED or more shortening is not always very appealing to patients. So I offer patients combination of all the ones that we talked about, depending on their goals, and how much is good enough. How much improvement in the curvature is good enough for you is typically my question after the ultrasound. So my patients have decided to do tractions with oral therapy alone, not very common since most patients have a lot of curvature, traction to increase length and go for plication or surgery, Xiaflex or intraregional collagenase alone or with traction. So we do have now a couple options that we can offer patients, but I think the multimodality treatment is usually good for most patients as they are coming with few complaints and concerns. And that's it. Thank you.